of us have been guided by models. It's been incredibly useful in hospitals to have some idea of what's going to happen next. And Patricia is from the University of Melbourne and is going to tell us which models we should believe in. Thank you.
Sort of. Okay. So firstly, my disclosures, which I haven't done a slide for, is I am a member of the Doherty Modelling Group. So we have done modelling for the Commonwealth Government supporting the National Reopening Plan, the Department of Foreign Affairs and Trade, and I've also done some modelling for the WHO. So the views that I'm going to express today are my own. Unlike what you might have expected and what you've seen this morning, there's no data in this presentation, so hopefully it'll be understandable to people who are not modellers. So firstly, what we've seen through the COVID pandemic is an absolute explosion of models for COVID. When I first started in this field back in 2010, modellers were those people who sat at the edge, they were weirdos, and modelling wasn't really a mainstream epidemiologic tool. And what I've seen since then is that it really has become such a tool and formed part of the evidence base. And we've really seen that. What we did see, though, through the pandemic is we saw a lot of models being developed perhaps by people who didn't necessarily have the epidemiologic understanding of how they should be used. And I think that that's really important, that we actually look at models in context. And modelling is an entirely interdisciplinary field, and we draw in people with a lot of different expertise. So we're not saying you can't have a physicist develop a model because they're great at doing modelling. We need to bring those skills together with people who can look at the public health aspects, the clinical aspects, the biomedical aspects. So it's very much an interdisciplinary field. So I was asked to present on which models were helpful. Now, obviously, I could get into quite a political conversation about that. Rather than do that, I've sort of avoided that question. We don't necessarily talk about whether models are helpful in a binary way. We don't say a model is helpful or it's not helpful. What we look at is whether a model is fit for purpose. So whether it was capable of answering the question for which it was designed, and whether people who are using the results of that model can actually rely on the conclusions that those people have drawn. So in order to do that, we actually have a set of criteria that we use to assess published work against. Typically, we're using it against a published model. So firstly, we expect that the model will have a clear primary research question because models need to be question specific. So not all models are capable of answering all questions. So we firstly look to see what was the question that they were trying to answer. We then have a look at what do we know about the disease and about transmission, and how have the modellers incorporated that into their model. So we want to see that they've looked at what the evidence is out there and how they've actually built that into their model. Population heterogeneity. So have they modelled the whole population as being one homogeneous group, or have they allowed for differences that might be important for both transmission or for clinical outcomes? So how have they managed to split the population? And did they use sources of data to develop their models? So what sort of data did they have available to them? So sometimes we can have models that are data-free. They're basically just a theoretical model. It doesn't mean that they're not useful. We can learn a lot from that. But how have these models actually incorporated data sources like our number of cases or mobility data, any information on different strains, antibodies, that sort of thing. Probably my most important point on this slide is uncertainty. How have the models incorporated uncertainty and how have they communicated that uncertainty? Because models are not perfect, they're not answers. We can't say they give us a solution that we rely on. We need to actually present them with the uncertainty because we're dealing with biological processes and people are involved and people are inherently uncertain and they don't always do what we might expect them to do. So we expect that models will acknowledge that uncertainty and actually include that in their results. And finally, when we're looking at whether models are fit for purpose, was it the most appropriate model to answer the question that the researchers had? So that's sort of what I'm going to come back to as I look at a few different models today. So firstly, models are designed for different purposes. So throughout the pandemic, we have seen a raft of different models. Typically, we have models for preparedness. Now, preparedness models are to mitigate the impact of infectious disease that has not yet hit our populations. So we don't know much about it in the current population. We then have real-time or nowcasting models, which are very, very short-term forecasts. So they're looking at the next 1 or 2 weeks ahead. They're telling us where we are and what we might expect in the very near future. Then we have forecasting models, which essentially are like these real-time and nowcasting models, but they're pushed out for a longer time frame and they tend to start looking at what-if scenarios. So different courses of action we might take, what's the likely impact of making those decisions? And then we're starting to see for COVID now some more retrospection, models that are looking backwards to try to actually understand the drivers of disease and calculate some of the parameters that we need to develop some of these longer forecasting models. I'm not going to talk about those today. There's only been a few of them that are published because we really needed to wait to have some data streams. So I'm going to really just focus on these 3 different types of models today that sort of follow the progression of the pandemic. And they all have different information needs and information available to them at the time that they were developed. So I'm just going to give a few examples, explain what they are, give a few examples and sort of a very qualitative look of whether or not they were fit for purpose. So preparedness models, as you might be aware, you've probably all seen this picture on the right, which is how we flatten the curve. So what we're trying to do here is before a pathogen or disease hits our shores, hits our population, we're trying to work out what we need to do to be able to keep the impacts of that infection within our healthcare capacity. So we apply a range of different hypothetical interventions to run some scenario modelling about what might happen if we were to implement these interventions. Because the pathogen hasn't hit our shores when this happens, we don't actually have any information of how this would spread in our populations. So we draw on experiences from other populations. And typically for COVID, we also drew on information and models that we already had prepared for influenza, which was what we sort of prepared for the next pandemic to be. Whereas we could use that and just adapt those models quite quickly. So I just wanted to give 3 examples of preparedness models that were developed in Australia and in different settings. Now, these models were all developed in February 2020, so they were available extremely quickly once we knew that there was a threat to a global pandemic. So in Australia, this is the work of Rob Moss and colleagues. It was based on prior work for influenza, which looked at coupling a transmission model, that is a standard compartmental model where we separate the population into susceptible, exposed people who've been infected but they're not yet able to infect anybody else. Then we have infectious people and recovered people. And we also, into that model, we can incorporate interventions such as isolating people who have been identified as cases and quarantining people who have been in close contact with them. So this model specifically couples those models together. We look at then a clinical pathways model where we look at healthcare utilisation in each of these groups. So people who become infected with mild or severe infection, how are they going to need GP appointments, emergency department, ICU, ward beds. And what these models showed was that the measures that we tried, the case isolation, the quarantine alone, were not going to be sufficient to constrain the pandemic within our capacity. Fairly similar story in the UK, who also used an SEIR compartmental model, applying the data from China about case fatality rates to estimate death. They don't specifically run through a clinical pathways model like the Australian model. And they tried 4 interventions, so school closures, social distancing, shielding people who were older than 70 years, and people who had symptoms, self-isolating. Again, they found that none of these interventions by themselves could actually constrain within capacity. In India, they looked at 2 interventions. One was symptomatic case isolation, and the other was port of entry screening. And what they found was that port of entry screening was actually a really terrible intervention. It would really only delay an outbreak by a few days at most, because I guess you only need to have 1 or 2 people get through that and you've lost it. So they did say that case isolation may reduce burden. That was using some very optimistic estimates. They had a very low reproduction number, and when they used a reproduction number of about 2.5 or 3, they actually found that they could only prevent about 2% of infection. So were they fit for purpose? Look, they had clear research question. They did reflect what was known at the time, which was not very much. We didn't have much information. They included some heterogeneity, so age, mostly. Risk, the UK model is stratified by location as well. The data sources they used was just a literature review, because that was all that we had. They all incorporated uncertainty and reported their results with that uncertainty. So I think they were all the most appropriate model to use at the time. So all of these preparedness models were fit for purpose. Let's move on to nowcasting models, or real-time models, and these models, don't try and unpick that graph on the left, it's just an example of some data that I've plotted. These are models that look at where we are now. They estimate the current growth and they predict future growth for next 1 or 2 weeks based on our current case counts. They can account for presentation and reporting delays. They're very short-term predictions, and they can measure the effectiveness of interventions. So we close things down, what happened? Here we had Australian data and the UK data, very similar process here. Both of these types of models were reported to authorities on a weekly basis, and in Australia that became part of the common operating picture. We measured in Australia, slightly different to other countries, we measured the effective reproduction number when we had cases, so how many new people did a case infect, but a lot of the time we didn't have any cases, so we had to come up with a novel method of what would the transmission risk be if we were to have a case. Whereas the UK had cases, so theirs was based on measuring at all times how many cases did an infected person infect. Japan, on the other hand, tried to develop a model that used regression modelling and publicly available data to estimate what the effective reproduction number was, but what they found was when they had stringent interventions in place, the model wasn't particularly successful. So I think all of these models were fit for purpose. The Japan model, to some extent, had a limitation that it didn't include much uncertainty. But otherwise, these models pretty much did what they were designed to do, which was to inform where we were at with all of our models. Now, our forecasting models, now this is one where the Doherty model that informed the national plan was what we might consider a forecasting model. It looks at a longer term likely prediction of what might happen. We look at calibrating, so choosing our model parameters based on what's already happened, and we look at what happens under different assumptions. Still for COVID, we're looking at forecasting quite short time frames, only a year or so in advance. I think you'd probably be quite brave to go further into the future at the moment, given the variant soup that's out there. Examples which I spoke about last year, the Doherty Model, where we actually looked at adding vaccine allocation model to an individual-based model to the clinical pathways model. So it incorporates a lot of heterogeneity and a lot of practical where we've actually been and our past history. The US model is calibrated to US historical death data. We can be a little bit more sure about death data when we're trying to choose parameter values for a model, and they project deaths only. And the UK similarly projects death with their models. So they do scenario modelling of 3 different types of vaccines. So models that reduce infectiousness, reduce symptoms and prevent infection. So they look at different ways of doing that. These models, obviously, Conway et al. Is the Australian model. I was part of that. I'm probably not going to get up here and tell you it wasn't fit for purpose. I think it's a great model. The US model, to some extent, I feel that at the time that it was done, they probably could have incorporated a bit more heterogeneity, and they had very limited uncertainty. They really just varied the basic reproduction number and used 2 values of the reproduction number. I think at this stage there's a lot more uncertainty than that. The UK model, similarly, I think was fit for purpose. So rather than telling you which models were helpful, I think the first statement that I'd like to make about all of these models, which are only very few of a wide array that are out there, is that all of them were the best that could be done at the time with the information that we had available. We might have thought that we had a lot of information at now, for example, but actually our information is becoming more and more murky. As Katie pointed out, with hybrid immunity, we're now at a position where it's becoming extremely difficult to actually model the type of immunity that a population has. The methods that we've used here, when you talk about models, you probably think instantly of the classic susceptible, infectious, recovered model that you might have heard of, but a lot of these models amalgamated mathematical, computational and statistical techniques together in the same model, and I think there's a place for all of those. They can all tell us something and lend something. Many of these models have contributed to the efforts of a country to control COVID in their population, but the most important aspect here for me is that communication of uncertainty. We have to get out there and let people know that we are dealing with uncertainty and that uncertain inputs mean uncertain outputs. And if by some coincidence it happens that we predicted exactly what happened, it's probably just a coincidence. So we need to be very careful, and our models are never right. They can predict within the bounds of uncertainty. And while I've focused here on separate models, ensemble models where we bring together the results of different models into a single model can actually be able to do better. Thank you.
Thank you. Questions? Yes.
Thanks for your presentation, Patricia. Very informative. Look, a couple of years ago I had to dissect the Doherty modelling for a piece of work, and it struck me that econometric modelling might have been an alternative, and to your last point on your last slide, provide a different perspective on, or at least another angle on the modelling. It was 30 years ago in my public health training with the Burnett, where I worked with a econometrician to develop a model for HCV, and it seemed to be, a very interesting way of modelling. Is that in use anywhere, to your knowledge?
So which particular type of model are you talking about? like a cost effectiveness model?
No, econometrics. It's widely used all over the world in transport and supply and.
I definitely wouldn't be an expert in that sort of modelling, so I don't know that I'd be qualified to talk about that. I think that there's a place for all different types of models though. And if somebody has a model that there is an application for, I think that we can look at that and bring them together. I wouldn't want to exclude anybody who thinks they can develop a model.
Right, okay, thanks so much.
There's a question on the table in the front.
Thanks, Trish. So Catherine Satsky from the Murdoch Children's. Really enjoyed your presentation, and just wondering if you can expand on the kind of communication of uncertainty, particularly for different groups. I think the general public, when they hear uncertainty, they think these people don't know what they're doing, or they don't kind of understand how to balance risks, and I think that probably feeds through to decision makers as well. So I guess what have you learnt in that space, and how could we do better in the future?
I mean, I think that graphs are a really good way to show uncertainty, but I think that you're very right, is that people want certainty, and that does flow on to decision makers. I've certainly been in a position where people would say, no, don't tell us that it ranges from here to here, tell us the value, how many deaths are we going to save by doing this? And it's like, we actually can't tell you. And I think that what we have learned through this is that communication needs communication experts and people who are really skilled at actually delivering these messages, and particularly around people who are hesitant about vaccines, for example. They don't want uncertainty. So we do have to be developing personalised messages for different audiences, I think.
Do you think the existential crisis of COVID has increased the issue of uncertainty and fear of the unknown?
One of the things that modellers are often criticised for is bringing uncertainty into things. But actually all that we do is just uncover the uncertainty that's already there. So life is uncertain. We never know exactly what's going to happen. And when we talk about an infectious disease, we're talking about biological processes, so things that happen to people within their body, but we're also talking about people's behaviour and how that's influenced by other people. So there's no way we can predict it with any certainty at all.
John?
The modelling is always challenging. I have a colleague at RMIT who's looking at, Professor of Biomass, who's trying to look at the modelling in older people. The issue, he can't get any information about vaccination status. And so the sort of issue that we really need to understand is in aged care settings, what are our policy options given all the hassles with lockdowns and keeping people away at the terminal part of life from their relatives, and yet they have a very high risk of COVID and are putting a burden on the staffing issue and on the persons there. His dilemma is to sort of look at all of this. He can't get access from anybody to unvaccinated data, and he's not a crank, he's trying to do that. So I guess where your group have access to the data, what's the step forward now for our long-term care institutions in terms of the policy mix that will get the best balance between giving people access that won't compromise the staff and do provide protection for people that are residents there?
I guess that really needs to look at somebody who is in charge of the data, as opposed to me as a modeller who uses the data. Certainly, a lot of the modelling that I do, I don't have access to any data, and so I need to look at scenarios and say, if the coverage was 50%, this might be what we could see. If it's 60%, this might be what we would see. So I guess in those circumstances, you could build scenarios around what would happen if it was certain levels, but really it then involves that, as you say, trying to develop those collaborations with the people who hold the data and actually be able to make a genuine case for getting access to the actual vaccination data.
From a GP perspective, that would be really useful for people that are looking at that to try and get that social protection balance.
Certainly, from my perspective, I think in communicable disease intelligence, vaccination coverage always were published, but I mean they're published in a very granular, very broad age groups and things like that. So I think it's going to be about trying to develop the collaborations and maybe hooking in with the modelling group, for example, and seeing whether there's something they can do.
Patricia, thank you. You've really explained uncertainty and of models incredibly well, and there's also the issue of having to break bad news, but we can discuss that over lunch. It is lunchtime, and we're due back at 1:40. Thanks, everyone.